Welcome to the virtual Yale School of Public Health, and thank you all for coming today. My name is Sten Vermund. I serve as the Dean of the School of Public Health, and this is the 9th jointly sponsored visiting speaker event beginning in 2012, and it was created by Dr. Gill, from whom you'll hear in a moment, who is director of our Pepper Center and also the Yale Program on Aging, and also created by our former dean, our Dean Emeritus, Paul Cleary. The goals of this lectureship are to enhance the visibility and prestige of aging-related research at our institution. We just like more and more people to take an interest in this vital topic. Also to encourage aging research collaborations between the Yale Program on Aging and the Yale School of Public Health, and sometimes even our guest speakers. So this year, we are delighted to also be partnering with the Yale School of Nursing, led by Dean Ann Kurth, and the synergies with the field of nursing are overwhelming. So why we didn't do this 9 years ago, I don't know, but we're doing it now, and that's a good thing. Let me just tell you a little bit about the Program on Aging and the Pepper Center. The Program on Aging at Yale was established in 1991 to promote and facilitate interdisciplinary and interdepartmental aging research. The resources were greatly strengthened the next year in 1992 when Yale was awarded a Claude D. Pepper Older Americans Independence Center. Those of you who don't know Claude D. Pepper are not my age, but he was a prominent congressperson from Florida who was a great champion of the aging agenda, and the program at the NIH was named after him. So currently, the POA, as we sometimes shorten it, the Program on Aging, has about 40 research projects funded by the NIA-sponsored Claude D. Pepper Center, and also by investigator-initiated NIH and foundation grants. There is a common thread of the research that's conducted at the Program on Aging, namely the development and testing of effective strategies for enhancing function and quality of life of older persons. And these persons are typically experiencing multiple impairments and chronic diseases. It may be diabetes, it may be something else. And we're doing this through our epidemiologic studies, our intervention trials, our outcome studies, and our social behavioral sciences work. So a major focus is the application of lessons learned from clinical trials to community health. Dare we call it implementation science. Now I want to introduce the director of the Pepper Center and of Yale's Program on Aging, Dr. Thomas Gill. Tom has his primary appointment in the School of Medicine, but we're happy to claim him with his secondary appointment in the School of Public Health, where he's active. And he's been a marvelous leader for this program, for the partnerships across the 3 schools, including nursing, and he will continue to introduce today's speaker.
Thank you, Stan. It gives me great pleasure to introduce Jennifer Wolfe as the 2020 Yale Visiting Professor in Aging. Dr. Wolfe is the Eugene and Milfred Lipsitz Professor in the Department of Health Policy and Management, and the director of the Roger C. Lipsitz Center for Integrated Healthcare at the Johns Hopkins Bloomberg School of Public Health. A lot of donors there, as you might notice. Dr. Wolfe received her PhD in Health Services Research from Johns Hopkins University in 2003 before she joined the faculty and then ascended the ranks to her current position. She's recognized nationally and internationally as one of the leading authorities on family caregiving. Her research focuses on the care of persons with complex health needs and disabilities, and on applied studies and initiatives directed at better supporting them and their family caregivers within systems of care delivery. Jennifer has served on multiple expert panels and consensus committees convened by the National Academies of Sciences, Engineering, and Medicine on the topics of family caregiving, home-based care, and dementia care. And most recently, she co-chaired the 2020 National Institute on Aging Dementia Care Summit, which made quite a splash recently. Just within the last 16 months, she's competed successfully for 5 new NIH grants as PI or multiple PI, including a new NIA training grant, a new demography center called the Economics of Alzheimer's Disease Center, and renewal of the National Study of Caregiving, or NSOC. For the past several years, she has served as a mentor to Catherine Riffin, who is a graduate of our own NIA T32 postdoctoral training program. We're delighted and honored that Dr. Wolf is able to talk with us this afternoon. The title of her presentation is Translating Observational Findings to Care Delivery Change, Supporting Families Caring for an Aging America. Welcome, Jennifer.
Thank you. I'm so honored to have been extended this invitation. I've been a long admirer of your work at Yale and the program on aging, and am delighted to share a little bit about my work on the science and policy of family caregiving. And I'm going to attempt to share my screen. So hopefully you can see my slide. So I'm going to start off my talk by discussing some of the disconnect between the science and policy of family caregiving, and how I and others have bridged this disconnect with observational survey-based data. I'll then talk more specifically about my research interests around better understanding and addressing the needs of family caregivers within the context of healthcare delivery. And then in the third part of my talk, we'll discuss a series of interventional studies that involve simple, low-cost systems-level efforts to better support and engage families within care delivery, with a focus on communication with older adults clinicians. And this is very much along the lines of moving towards implementation science, which was just mentioned at the beginning of the talk. I plan to talk for about 45 minutes so that we have time for discussion. I realize that we are several minutes into the talk, so I will try to be expeditious in my comments. So although the World Health Organization characterizes family as the primary social agent in the promotion of health and well-being, there's a tremendous disconnect between science and advocacy and policy that has inhibited evidence-informed policy and practice. A foundational challenge with respect to descriptive research is that a lack of consensus about the terminology and defining features of family caregiving has impeded a shared understanding of the concept, how we measure it, and agreement on basic facts that enable a coherent policy agenda. For example, the terminology in this area is a little bit of a word salad, ranging from informal to family to care partner or proxy. And because of the diffuse and wide-ranging nature of family exchanges and family caregiving, the directionality and magnitude of consequences for caregivers and those they help are a little bit all over the map in the research literature. With respect to explanatory and interventional studies, these have traditionally been developed in small disease-specific samples of at-risk caregivers and focused on a single primary caregiver, and have largely been conducted outside of care delivery without a clear pipeline towards subsequent scaling. As a result, although promising evidence-based interventions from randomized trials have been developed, the implementation science bottleneck has meant that very few interventions reach the intended target population or are developed with a mechanism for dissemination. And the reality is that very few caregivers now benefit from evidence-based supports. So these headlines are emblematic of a prevailing narrative that has been put forward by the advocacy community, which has made the case that family caregiving is significant due to being big and consequential and affecting tens of millions of families, with with a shift towards fewer available caregivers to help a growing number of older adults. This narrative has characterized family caregiving as a universal, monolithic, burdensome experience. And I would argue that this narrative has been a barrier to developing a strong policy approach for action because it has failed to acknowledge the vast heterogeneity of families and caregiving circumstances and has diminished the fact that it's a much smaller subset of people whose lives are profoundly affected at a given point in time than the 4 in 10 Americans who've been identified by the advocacy community with the label of caregiver. As we all know, effective and clinical and policy interventions require having an understanding for whom and under what circumstances additional support is needed. And this policy narrative has largely failed to shine a spotlight on effective settings and strategies for systematic identification of caregivers. So it turns out that the estimated numbers of caregivers depends in part on who one asks. This is a figure from a 2010 paper led by a former doctoral student, Erin Giovanetti. And in her dissertation, she comprehensively assessed design aspects from 8 national surveys of family caregivers to older adults and found that the estimated numbers varied by about tenfold, with a major point of departure being whether the survey was conducted in a defined population of older adults involving questions about a defined set of tasks over a specific time period, and then identifying how those activities were undertaken and by whom, as opposed to random digit dial approaches which ask individuals to self-identify as a caregiver, as shown on the right. This study by Erin Giovanetti was published in 2010, and the National Health and Aging Trends Study and its linked national studies of caregivers, which was mentioned by Dr. Gill, is funded by the National Institute on Aging and led by Judy Casper, was first fielded in 2011. The National Health and Aging Trends Study, or NHATS, is a 2-hour in-person survey that's conducted annually with a nationally representative sample of about 8,000 older adults. The National Study of Caregivers, or NSOC, is administered to all the family and unpaid caregivers who help older participants in NHATS who are receiving help for health and function reasons, not just a primary caregiver, which has traditionally been the approach used to assess family caregivers in disability surveys. In addition to other innovations, these 2 surveys are unique in that they are the only contemporary national representative data platform that collects linked information from both older adults as well as the family and other unpaid helpers who help them, and it includes caregivers of older adults living in residential care facilities. With respect to the numbers of family caregivers, estimates from these more recent surveys indicate that about 18 million family and unpaid caregivers were helping older adults in the community and in residential care settings other than nursing homes in 2011. These estimates are considerably higher than prior disability surveys, but far less than surveys that ask caregivers to self-identify without reference to a defined target population receiving help. Very importantly, these estimates from the National Study of Caregiving have really changed the policy dialogue and led to more of a consensus between the scientific and advocacy communities with respect to the size of this quote unquote healthcare workforce. These new estimates were widely used in the 2016 National Academies of Sciences, Engineering, and Medicine report, Families Caring for an Aging America, and have subsequently led to a change in the policy dialogue, both in, here we can see an editorial in The Lancet that refers to 18 million family caregivers. In a New England Journal of Medicine perspective, we drew attention to the fact that it's a smaller group of about 6.5 million caregivers who were found to be helping older adults with substantial care needs due to dementia or needing help with 2 or more self-care activities. So the ability to draw on these linked national surveys to examine subpopulations and aspects of care delivery can be a powerful way to highlight otherwise poorly understood or invisible aspects of care. These data have been important in recalibrating what we know about caregiving at the population level and in understanding subpopulations of caregivers. For example, a 2015 Health Affairs paper led by Judy Casper finds that about 10% of older adults with dementia account for about 40% of all caregiving hours. A 2017 Health Affairs paper led by Catherine Ornstein found that the demands of end-of-life caregiving are highly affected by the type and trajectory of illness, but are far less pronounced than studies that had been previously published in convenience samples or that had focused on a single primary caregiver. Your very own Catherine Riffin used these linked NHATS NSOC platform to highlight the large numbers of non-dementia caregivers who are also highly affected by care provision, and in particular, the importance of task-related activities on perceptions of burden. Cheney Fabius recently led a paper in the Gerontologist demonstrating that Black caregivers are far more likely to be providing higher intensity care of 40 hours or more per week to an older adult who is living with dementia and who was living below the federal poverty line, but surprisingly were more likely to report gains and less likely to report emotional difficulty than white caregivers. A paper that I led in the Gerontologist draws on 4 waves of linked disability and caregiver surveys over a 16-year time period to assess the changing composition and experiences of family caregivers to older adults with substantial disability, defined as self-care or mobility disability, between 1999 and 2015, using the NHATS and NSOC, as well as the predecessor survey, the National Long-Term Care Survey, and its informal caregiver survey. Here we focus only on primary caregivers due to the design of the National Long-Term Care Survey and its informal caregiver survey. We found no evidence of what the advocacy community has labeled a caregiving cliff relating to reduced availability of family caregivers, but that the population of older adults receiving help is in general over time younger, better educated, and in better health, reflecting the early stages of the baby boomers who are reaching age 65. Importantly, in our study, we observe incremental declines in the percentage of caregivers reporting substantial emotional, physical, and financial difficulty over the 16-year period, and that the percentage of caregivers using respite roughly doubled between 1999 and 2015 from 9 to 16%, which is consistent with the introduction of the National Family Caregiver Support Program in 2000, which made respite care and other services available through the Aging Network. Importantly, we reported findings stratified by caregiver relationship, and we found, importantly, that the observed reductions in difficulty related to caregiving were predominantly experienced among spousal caregivers who are helping this younger and less impaired subset of the population, but we observed no differences among adult-child caregivers. These studies all contribute population-level information that counterbalances, to some extent, the prevailing narrative that's been advanced by the advocacy community and speaks to the feasibility and the importance and the benefit of monitoring caregivers in light of concerns related to population aging. And I would argue this kind of information is increasingly important as the aging of the baby boomers continues into greater ages where individuals are at greater risk for substantial disability and dementia. So I'll shift gears now to talk more specifically about the growing attention to the role of family caregivers in care delivery processes, setting the stage for care delivery being a setting of intervention. One of my first opportunities to engage in policy as a newly minted assistant professor was when I was asked to draft one of the background papers for the IOM Retooling for an Aging America report. And this experience was highly influential in crystallizing my thinking about caregivers as a quote-unquote workforce. Within the context of the report, it was particularly striking to contrast the professional healthcare workforce, which is well educated and credentialed to function within a clearly defined scope of practice and in highly controlled delivery settings, with family caregivers who accidentally fall into their role, typically without any education or preparation, and who provide help in wildly varied home environments, most of which were not set up for care delivery. In evaluating the evidence, it was clear that despite largely being anecdotal, that family caregivers are in many ways the ultimate in integrated care, and that they follow patients across settings from hospital to post-acute care to the nursing home and then back home, and really are patching together the fragmented service delivery environment and assisting with varied and complex activities that span personal care and homemaking to complex coordination of care and medical management, some of which are listed on the slide. This 2001 quote from the AMA captures the idea that America overwhelmingly relies on a stealth weapon and a shadow workforce of family caregivers. A big challenge with respect to interventional studies and systems change is that family caregivers are largely invisible in care delivery. Because they operate outside formally recognized professional practice, financing, and regulatory arrangements, their presence is not systematically captured in a way that allows an understanding of how often they're involved, who they help, what they do, or how their involvement affects care outcomes. So the NHATS and NSOC provide unique opportunities to assess the experiences of family caregivers, due in part by the inclusion of more granular questions about healthcare and work than in prior national surveys of caregivers. This paper, led by our doctoral student, now postdoctoral fellow, Julia Bergdorf, found that less than 10% of caregivers reported receiving training related to caregiving responsibilities in the prior year. And I realize you can't read any of the small numbers in the table, but we found importantly that neither older adults' health status nor caregiver burden were associated with receipt of training. Instead, the key drivers related to whether the older adult was hospitalized and whether the caregiver was paid for providing care, for example, from the Medicaid program. And this really sort of speaks to the importance of care delivery as a setting for these types of interventions. In another JAMA Internal Medicine article, my colleagues and I presented findings from these linked NHATS NSOC surveys regarding how caregiver involvement in older adults' healthcare activities relates to the types and intensity of caregiving roles, supportive services use, and caregiving related effects. We focused in this study on caregivers who are helping with two prevalent, clinically important health management activities. And we compared caregivers who both coordinated care with health professionals and managed medications, which we defined as substantial healthcare help, with those who did not provide this help. And we had three main findings. First, about half of the caregivers who are helping older adults living in the community were providing substantial healthcare help. And about 1 in 4 of these caregivers reported their own health to be fair or poor, and nearly half were helping an older adult with dementia. Secondly, we found that caregivers who are providing substantial healthcare help provided significantly more hours of care than those who did not provide this help. On average, about 28 hours of care per week is shown in dark blue on the left panel. And we found, as shown on the right panel, that just 1 in 4 used respite care, participated in the support group, or received training or education about how to provide care. Third, and most important, we found that caregivers who were providing substantial healthcare help, shown in darker blue, were about twice as likely to experience significant emotional, physical, or financial difficulty relative to those who did not provide this help. They were more than 5 times as likely to experience reduced participation in social and leisure activities that they identified as important to them. And although rates of employment did not differ, those who provided substantial healthcare help were 3 times more likely to experience work productivity loss relative to those who did not provide this type of help. And this study, I think, is important in establishing that the hard work of managing complex care extends beyond patients and health professionals to family caregivers, and also suggests that the ability to identify at-risk caregivers within systems of care is potentially a viable strategy for finding them. So this quote from a 60-year-old woman who talked to our team about her interactions with the primary care providers who assist her husband with mild cognitive impairment provides some insight as to the experiences of family caregivers. And she talks about how clinicians often get angry with her and ask her to let her husband speak and how difficult this is. The main point is that a lack of a defined role for family caregivers within systems of care presents a number of challenges with respect to face-to-face and electronic interactions, and can too often leave family caregivers in an adversarial position with respect to their ability to advocate for the patient, have a voice in communication, or being able to access information that is appropriate and beneficial when they're involved in coordinating or overseeing care with other providers. In a JAMA Network Open paper published earlier this year that draws on a new NSOC module about healthcare, family caregivers' health system interactions, we found that about 1/3 of caregivers reported speaking with or emailing with older adults healthcare workers sometimes or rarely, and about 10% reported doing so often. Among these caregivers, the experiences with older adults healthcare workers varied markedly across types of communication support. As shown in the far left bar in the darker two shaded segments, we found that about 90% of caregivers reported that older adults healthcare workers always or usually listened to what they had to say. Shown in the middle bar, we found that about 2/3 of caregivers reported they were always or usually asked about their understanding of older adults' treatments. And shown in the far right bar, we found that just about 1/3 of caregivers reported that older adults healthcare workers always or usually asked about needed help managing older adults treatments, and nearly half were never asked. Importantly, we looked at these items across older family caregivers to older adults with dementia and found very few differences. Although more dementia caregivers reported that they were asked about needed help, 4 in 10 reported that they were never asked. So an important thread of my work has focused on understanding how older adults and family caregivers engage in health system interactions and encounters. And we have, this overwhelmingly indicates that family-centered care is a reality. For example, in a 2012 supplemental module of NHATS, authored by Cynthia Boyd and myself, we confirmed that older adults who are more vulnerable across dimensions of age, education, and health commonly rely on or delegate decisional authority about their care to family members. In a series of papers involving national surveys and as well as meta-analyses, we find that about 4 in 10 older adults regularly attend medical visits with family and other unpaid visit, what we call companions, since they are not necessarily providing hands-on help. And we find these companions are not just present at a single visit, but are involved longitudinally over time. Secondary analyses of audio-taped clinical encounters find that these visit companions are not simply present during the encounter, but they actively communicate in ways that both facilitate and impede information exchange. And my last slide on this particular issue relates to the opportunities of the linked NHATS and NSOC to evaluate bidirectional relationships and how caregivers may affect older adults' subsequent care and services, drawing on linkages to Medicare assessments and claims data. A series of papers led by myself, by Julia Bergdorf, and by your own Halima Amjad find that family caregiver factors, including caregiving-related strain, are related to older adults' subsequent services use, including long-stay nursing home entry, emergency department visits, and hospitalizations after accounting for older adult and caregiving characteristics and circumstances. I'll say here that importantly, the National Study of Caregivers will involve annual data collection after NHATS replenishment in 2021, which will set the stage for greater ability to examine granular effects related to changing circumstances of family caregivers and helping networks over time, and potentially how they affect services use. So now I'm going to shift gears and talk about engaging family caregivers in care delivery. Importantly, one of the main recommendations from the 2016 NASM report relates to the need for greater attention to systematic identification, assessment, and support of caregivers throughout care delivery processes. And this has really motivated a lot of interest by payers, funders, and care delivery organizations. So there's a lot of exciting progress happening in the field at this time. I think I'd like to just acknowledge Susan McDaniel's excellent book, Family-Oriented Primary Care, which really lays out a compelling case that attending to and supporting the family caregiver, quote unquote, workforce may be among the greatest untapped strategies in high value care. So I wanted to just reprise this slide, which highlights the notable gaps in the diffusion of evidence-based approaches towards supporting families within care delivery. And I'm going to talk now about a line of developmental work, which has been directed at the idea of developing simple, scalable strategies to identify and engage family caregivers at the point of care, focusing on what I think of as the patient-family partnership in health system interactions. These strategies all have been developed to leave a relatively light footprint on information systems and clinical workflows so as to facilitate the feasibility of diffusion. And I'll talk in most detail about the first of these strategies around patient-family agenda setting, which has really been foundational in my thinking about this line of work. So the main focus of my interventional work has been directed at communication, which has been described as the main ingredient in care, as it involves establishing a trusted relationship to foster the sharing of information between patients and clinicians, the exchange, the deliberation and making decisions about a clinical course of action. There's been a growing appreciation in recent years that although clinicians are experts on clinical care prognosis and treatments, that patients are experts on their bodies, their lives, their values, and their preferences. Therefore, patient participation in care is not optional. It is essential in the delivery of high quality care. And there's a robust field that's been devoted to patient engagement, with prior work finding that pre-visit interventions such as agenda setting, question prompts, and coaching can increase patient participation and satisfaction in care. An important caveat is that not all patients have the capacity to participate in care, and a subset of patients, in fact, prefer to delegate decisional authority to families. Although patients endorse involving family to bridge communication challenges for patients who lack the capacity and the desire to participate actively in care, there's been a lack of evidence-based strategies that suggest exactly how to do so. So these quotes provide a sense of the kind of dialogue that occurs in geriatrics clinic, and obviously this is familiar to those of the geriatricians who are listening. And although these quotes, I think, highlight the instrumental role that families assume in ensuring productive information exchange. And although the capacity of families to engage in care delivery interactions and facilitate the delivery of hands-on help undoubtedly affect care quality and outcomes, as I mentioned earlier, due to data constraints, evidence in this regard is relatively weak. So through a series of iterative projects involving a highly interdisciplinary team, we've developed and pilot tested several versions of a patient-family agenda setting checklist, which is really predicated on the idea that these family companions are motivated to support patients during medical visits, but often don't know what patients' concerns are or their preferences for assistance during the visit. And so the checklist has two activities that are designed to help patients and families get on the same page by aligning their perspectives about the patient's health concerns, to set a visit agenda, and to clarify the role of the companion in the visit. And so this is just an image of the paper pencil checklist. The checklist first asks the patient and the companion before a visit to clarify the role of the companion from 5 activities that span passive listening to prompting the patient to ask their questions, to communicating directly with the clinician, or leaving the patient alone for some or all of the visit. In the second step, the patients and family are asked to consider together what they want to discuss with the clinician from common concerns that are known to be underdiagnosed and underdiscussed in primary care. And the checklist explicitly lists a place for the patients and the companions to identify their concerns as being distinct, but isn't really overly prescribed with respect to instructions that could be misinterpreted or not read. So we tested this checklist in a trial involving 93 patient-family dyads under the care of 14 clinicians from 3 primary care practices. We enrolled 93 patient family dyads who met eligibility criteria on the basis of a telephone screening interview and the patient having cognitive impairment and reporting that they regularly attend visits with the companion. We randomized 49 dyads to the checklist and 44 to usual care. We all of the participants attended their visits as usual, which was audio taped, and then they responded to follow-up visits at 2 weeks. The patients were on average about 80 years of age. They had a mini-mental score of 21, which is sort of between the threshold of mild and moderate cognitive impairment. About half had a diagnosis of dementia in the electronic health record. And caregivers were on average about 62, and they had in overall higher health literacy and higher educational attainment than the patients. Here are just a few of the quotes that our team collected from interacting with participants. The visits themselves involved very complex, difficult discussions, a lot of discussions relating to safety and autonomy concerns around topics like managing medications and driving, safety of living arrangements, as well as issues such as wandering, problem behaviors, and falls. Here I show how the 49 intervention participants responded to the checklist. Overall, they identified an active role for the visit companion. 85% selected 3 or more of the active communication behaviors. In step 2, patients and companions identified an average of about 4 concerns for the visit agenda. Importantly, the patients and companions sometimes agreed and sometimes didn't entirely agree about the specific visit agenda. We see in the left panel that the more objective issues related to hearing and vision, fear of falls, and bladder and bowel problems were similarly identified by patients shown in blue and companions shown in red. In the right panel, we see that patients were more likely than companions to identify memory problems and symptoms of depression and anxiety as a concern, whereas companions were more likely than patients to identify safety and behavior changes as a concern. In other words, patients were more concerned about memory loss, and companions were more concerned about the ramifications of managing memory loss, suggesting the differences in perspectives that each bring to the discussion. So our primary outcome was a measure of patient-centered communication from coded visit audio tapes, where the numerator encompasses more patient-family directed types of interactions, and the denominator more biomedically oriented physician-driven communication. We see that overall there were fairly profound shifts in the nature of communication towards more patient-centered conversations and discussions of sort of lifestyle and psychosocial issues relative to the usual care group. Also importantly, we see that there were differences across the 3 clinics, such that there was little to no difference in the geriatrics clinic, and we see much larger changes in communication for the 2 general primary care clinics. A secondary outcome was companion verbal activity, and we see that in the checklist group that companions tended to be more verbally active, contributing about 23% of visit dialogue relative to 18% in the usual care group. And we see this is true across all 3 clinics, but again, more pronounced in the 2 regular primary care clinics relative to the geriatrics clinic. And then finally, in terms of visit duration, we see relatively small differences in visit duration across the 3 clinics and as well as overall, which is critically important in thinking about scalability and diffusion. We did ask intervention patients and companions about their experiences completing the checklist at follow-up, and most stated the amount of time completing the checklist was just right, and they endorsed the checklist as being easy, useful, helping them to prepare for their visit, and clarifying how the caregiver could help. They overwhelmingly said that it improved their sense of control and they would recommend it to others. So there are a number of positive main takeaways with respect to acceptability and promise of this strategy. One of the key takeaways was that nearly all patient participants wanted their families to have access to their electronic health information. And I realize that I am running short on time, so I'll briefly talk about this other line of inquiry around trying to understand current practices relating to patients to shared or proxy access to the patient portal. So as all of us likely know, the patient portal is a personal health record tethered to an electronic health record through which individuals can view test results, sections of their medical record, perform health management tasks, and communicate with clinicians using secure email. And there's also a documented digital divide where those who are older, less educated, and with less technical experience are less likely to access and use the patient portal. Although most vendors do allow patients to share access to their health information through a registration process where a family member or friend has their own identity credentials, uptake of this is relatively limited. However, this is an important potential strategy that would respect patients' preferences for involving their families and allowing them to have information access, for providing family members greater legitimacy when interacting with the care delivery system, and providing them with timely, comprehensive, and accurate information about the patient's health. It also importantly allows clinicians to understand who it is they're interacting with electronically. So in a series of descriptive papers, we have evaluated and found evaluated uptake of shared access and found that it is widely offered by integrated delivery systems, but that limited information is available about registration procedures and functionality on institutional websites. And we have found, and in partnership with colleagues at Geisinger Health System, that there's been minimal uptake of shared access in routine care, despite potential benefits. We are completing a pilot study in oncology where we expanded the agenda setting checklist to ask about patients' preferences for providing shared access functionality. And in a, we are working on our final paper where we evaluate issues around patients' experiences with care and illness understanding at 12 months. However, in a paper where we evaluated short-term outcomes, we found that 80% of patients in both intervention and control groups wanted families to have access to the record. Intervention patients and companions were highly aligned about visit concerns, and about 3/4 of intervention dyads elected to register the care partner for MyChart. So in my last few minutes, and I'm not sure why the sharing is moving around, I want to just share a little bit about a series of new projects that are getting underway that are focused on testing systems level scalable strategies to improve care and issues related to implementation science. So there's a growing recognition that the benefits of science occur when evidence is translated into mainstream practice, but that the traditional approach to this research to policy and practice pipeline is not efficient. And there's been a growing awareness of the importance of implementation science. 2014 paper by Lisa Onken provides a comprehensive overview of the NIA stage model, which is critically useful for those of us who are interested in behavioral interventions. Importantly, this model defines the intervention development process as incomplete until an intervention is optimally efficacious and implementable with fidelity by practitioners in the community. So there's a much more of a focus on developing an evidence base that's built for scaling. And I would just want to say that it's really important that this issue is not prescriptive or linear, and it affords for multiple feedback loops and sequences, but there's a heavy emphasis on both implementation and the ability to deploy interventions in the real world, as well as theory and understanding the change mechanisms that underlie observed effects. And I think NIA, this paper is helpful in understanding NIA's orientation to thinking about what kinds of interventions they want to fund. The article also speaks to the importance of preparing the next generation of scientists to lead this work. And I think this model is highly aligned with environments like Johns Hopkins University, as well as Yale, that bridge public health and medicine. And so after many years of in the realm of stage 0, which is sort of pre-intervention work, and stage 1, sort of developmental and pilot testing work, I'm moving into a thinking on a daily basis about the stage models 3 through 5, and launching 2 complementary trials that are focused on improving advanced care planning for older adults in primary care, as well as a planning phase project that's meant to lead a demonstration of organizational strategies to spread shared access to the patient portal. And we're working with 3 care delivery organizations, sort of taking what do we know and how do we actually increase appropriate uptake of shared access in service delivery lines that involve the care of individuals and older adults with serious illness. And so just, I want to end briefly, but I just want to acknowledge this advanced care planning in terms of the rationale is really predicated on the idea that there's been a shift in thinking about advanced care planning as a legal transaction of completing advanced directive to being a longitudinal communication process that selects and includes a healthcare agent in ongoing care. And despite the importance of planning for future care needs in the context of dementia, and the important role of families in ensuring primary care and quality of care for older adults with cognitive impairment, relatively few interventions target advanced care planning in primary care that have included persons with dementia. And so the work that we are undertaking in 2 related trials, an efficacy trial of SHARE and a pragmatic trial of sharing choices, are a multi-component intervention that's meant to normalize advanced care planning through a mailed letter that introduces an initiative to prepare patients and families, including the agenda setting checklist, including facilitated and promoting facilitated registration to the patient portal, providing access to a non-clinician facilitator who's trained to lead ACP discussions and who's been trained in the Respecting Choices curriculum, as well as resources about dementia. And the components of the interventions are the same, but the studies are wildly different in design. And so the efficacy study is focusing on a highly selected sample of 250 at-risk older adults, and is focusing on the question, does the intervention work? And Sharing Choices, which is a cluster randomized trial at the clinic level, is focusing on the outcomes of advanced directive documentation and burdensome end-of-life care and that are collected in routine care, and are addressing the question, does the intervention work in routine care with little or no selection? And so I just wanted to finish on an optimistic note, which is to sort of put this work that I'm doing in a broader context and recognize the tremendous work that's happening with respect to policy and care delivery reform. And so at the state level, there's a lot of shift and increased intention around paid family leave, efforts to support families through the hospital discharge process, and efforts through the Aging Network to really better support families through the National Family Caregiver Support Program. And on the federal level, there's a tremendous effort through Medicare to promote support for families around that afford the opportunity to work with families through payment reform, such that are listed here on the slide around new billing codes, as well as conditions of participation. And notably the passage of the RAISE Family Caregiver Act, which has led to the Family Caregiver Advisory Council, which is really that came out of the NASM Families Caring for an Aging America report, and is motivated around developing a national strategy to really think about how do we support families in a holistic way across multiple levels, from the care delivery system, both healthcare and long-term care, to state policy. And I think overall, it's a really exciting time to be doing work in this area, given all of the effort that's happening at multiple, state and local levels, the federal level, as well as the real focus of the National Institute on Health and the National Institute on Aging through these trying to think about how do we do research differently. And so I'm just going to end by acknowledging that health services research is very much a team sport, and everything that I've talked about today has really been the result of amazing collaborations by many folks whose names are listed here on the slide. So I'll stop and take any questions.
Hi, everyone. So if you want to just put in the chat box any questions you have for Dr. Wolf, I can read those. And if we're waiting for any questions, I have a question to start off with. I'm really interested in thinking about the discrepancies of patients and caregivers and what their kind of needs and preferences are, and how you think that might be integrated into giving advice to clinicians or in med school if we need to start earlier on kind of navigating who should be the priority in some of those gray area discrepancies.
I mean, that's such a great question. I think it's, as a non-clinician, it's very difficult for me to think about how I would make recommendations about that, other than to acknowledge that the real challenges around patient autonomy, and that the heavy focus in care delivery really is around the patient. And I think that, you know, it raised some of the challenges in thinking about interventions in this space relate to issues around I guess issues around the legality of identifying family needs when the family is not under the care of the clinician. And so a lot of the work that I have done has really sort of danced around this issue through focusing on, you know, the patient-family dyad, and focusing on the patient preferences in the context of the shared access to the patient portal. But I agree that thinking sort of more broadly about, I understand that there is a tremendous need for educational curriculum to prepare clinicians and other healthcare workers to interact with family caregivers because of these complexity and a lot of concerns about opening up Pandora's box around toxic interpersonal relationships.
Okay, oh, sorry, Tom, we have a question from Dr. Vermund. Should I say that?
No, Deans go first.
Okay, given that NIA support at the NIH has been relatively immune to which political party is in the White House, Senate, or House, do you see aging research or policy changing based on the November 3rd election results?
Wow, that's a great question. Well, I think for my sense is that this is really an exciting time for those who are doing work around aging with respect to dementia because of the additional dementia monies. So I'm not sure that what happens in November will affect that. And as far as policy, I really feel like family caregiving is sort of like moms and apple pie. Like it's really sort of not a political issue, because I think all of us really can recognize the importance of families and supporting families. So I believe that the future is bright regardless of what happens in November with respect to family caregiving, I would say.
That was quite an impressive body of research completed and ongoing. And you may not have had time to give this much thought, but I'm just curious about some of the challenges currently with COVID in terms of the patient caregiver dyad, and if you've been involved in any way, and what are the things that we should be thinking about, or the care delivery system should be thinking about to be able to accommodate some of the competing considerations in the pandemic? Yeah,
no, that's such a great question. This came up earlier when I was speaking with Dean Vermund. I think every day, in just looking at in the lay media, I see, you know, the shocking and profoundly upsetting issues around care delivery for those who in particular are most vulnerable, and in, you know, living in nursing homes, and who are either the direct care workers who care for older adults who are in the community, who are, you know, often tasked with providing help without the right protective equipment. So I think COVID has really sort of exposed the underbelly of, you know, challenges in particular for older adults and caregivers who are most vulnerable. So the two studies that I mentioned that are getting underway were initially planned to be involved in-person data collection and enrollment, and we've had to reconfigure them for remote, which has presented a number of challenges, but nevertheless we've moved forward because of the fact that this work is critically important now, even more so than before. So I think there are opportunities with respect to research, but I think that the challenges are very real, and I think in particular for with respect to those populations who are most vulnerable. I don't know, I could go on and on. There's like so many different issues around, what is caregiving in the context of COVID when you're managing, work. The work environments are different. The questions from NHATS are very different. What is being socially isolated in the context of COVID? So I'm not sure I can really do your question justice in a brief way.
We have a question from Peg Graham. Such a pleasure. Thank you for sharing your work. I've been following NHATS for quite some time. From my own family caregiving experience, I've been tackling the manual demand of caregiving, taking on toileting assistance in particular. I've noted that there appears to be a Chinese wall between those taking on the behavioral changes involved in resolving family challenges and those creating innovation in assistive devices. Do you think that these two worlds could be working closer?
Wow, that's a great question. So I agree that there is one of the challenges about family caregiving is that it is all encompassing, and it's so variable in terms of the activities, the financial assistance to insurance to managing medications, assistive devices, and these sort of interpersonal relationships. So I'm sure that, I think that a lot of the exciting innovation comes from bridging different disciplines. So I am sure that there could be opportunities for working more closely together. I think that some of the activities that you've listed around toileting assistance are those that are particularly difficult for families.
All right, well, it's 12:59, so I'm not sure if I'm supposed to be the one to bid you adieu, but it was so wonderful having you here.
Thank you. It's my pleasure. I'm really very honored to have been invited and to have the chance to present.
All right.
Hi, can I ask a question?
Oh, we have one last question if we want to stay
Yeah,
up.
it's a very stark difference actually because I'm originally from Indonesia. So yeah, just to give you the context here, it's actually usually we don't usually send our parents to the nursing home. So usually the caregivers are actually a member of the families. So I was just curious, is there some sort of like classes or program provided by the government there in the States? Because here in Indonesia, for the caregivers, actually you have to attend some sort of classes just so that you know what critical care that you should give to your parents at home. And also it's very sometimes here in Indonesia the problems are more likely to be the emotional issues that having to take care of your parents. So yeah, can you just like give us some advice or any suggestion on that? Thank you.
Sure. So my understanding is that in Indonesia, there's an expectation that there's some sort of level of competence in specific tasks for those who are providing care. Here, I don't believe, I think there is a lot of evidence and work that's been developed around types of training programs. It's almost like there's too much information for those who look online. It can be overwhelming. So there isn't a single go-to source, but the RAISE Caregiving Council that I mentioned is sort of working to develop stronger research infrastructure that would bridge policy and practice to make evidence-based educational programs and other kinds of models available more broadly. So, here I think that we are not necessarily leading the way, and so it's perhaps the case that we could learn a thing or two from those in Indonesia where you're from.
All right, so we can end now. And for any of the fellows or junior faculty that have remaining questions, I'm sure Jennifer, you would be happy to get an email.
Absolutely.
Okay, well, thank you, everybody. Have a great day.